Now Dr. Vishal will prognosticate the largest topic, the diabetic retinopathy and RVOs.
So thank you, Rama, for giving me this topic. As Rama said, it's a huge topic. I'll just cover all, as I talk to him, all the proven, prognosticating factors and not the hypothetical ones which are still in controversy. So my topic is predicting long-term prognosis in diabetic retinopathy and RVOs at presentation. So, it involves, in both these diseases, it involves various factors apart from the ocular factors as we know, as opposed to AMD, like type of disease, stage of presentation, whether it's, a simple NPDR, even if the patient is euglycemic, or a very late stage RVO with the new vascularization. The areas of involvement, of course, if there's a peripheral involvement with a very good vision, and if the patient has a macular ischemia, or the number of prolapse and the extent of prolapse, the treatment efficacy, you're going in with anti-VEGF, but the patient is responding to anti-VEGF, or you need to switch and you are taking it lightly. Patient systemic health, of course, you have to be in consultation with your physician or endocrinologist, and patient compliance with treatment is a very important factor, because these are long-term treatments, not a one single shot of anti-VEGF or a one single sitting of laser. So how compliant the patient is with the follow-ups. Lifestyle modification, as hard as we might try, lifestyle modifications are very difficult to modify, easily said than done. And the complications, of course, associated with all these post-laser hemorrhages, post-injection macular holes, these are all. And finally, ocular comorbidity, whether the patient, along with the diabetic retinopathy, NRVO has glaucoma or other comorbid conditions. So, collaborative care with physician and endocrinologist is essential for optimizing patient care and improving prognosis. And the systemic management includes glycemic control, the hypertension management, lipid-lowering therapy, and cardiovascular risk reduction. Of course, this is a very large topic, and I will be concentrating on the factors in the eye. And for that, there are diagnostic tools now, excellent diagnostic tools, which aid in assessing disease progression. And the most commonly used, as we all know, is OCT and fundus photography, and now the ultra-wide field fundus photography, OCT angiography, visual field testing, and deep machine learning. So the bottom line is objective analysis in any disease, along with multimodal imaging in eye, is the future now. So the current imaging modalities play an important role in deciding the treatment protocol, as well as prognosticating the outcome. And we have now various imaging biomarkers which provide the assessment of the health of the retina, and a near histological assessment of the capillary density and FAZ. Coming to the OCT, spectral domain OCT and SSOT are the most advanced technology available to evaluate the macular health at present, which is very important in these two conditions. So coming to the biomarkers, many of these biomarkers are overlapping in both the diseases, diabetic retinopathy as well as RVO. The first and the most common thing we see when a diabetic patient with macular edema comes is retinal thickness, of course, the CST, central subfield thickness, which can easily be monitored in the OCT and measured. But despite that, despite the resolution of the DME and the amount of DME, the gain in vision might be suboptimal. And it might be, after the treatment, it might decrease also because of the macular atrophy, because of long-standing edema and resulting damage to the photoreceptor. So therefore, central subfield thickness is not a good prognostic or predictive marker of final visual outcome. The other things which you have to look along with macular edema is the duration of the edema, the pattern of the edema, the extent of the retinal involvement, the layers involved, and the differential involvement of inner versus outer retinal tissue, and the status of the photoreceptor. Coming to the second most common thing which we see in a diabetic macular edema is cystoid spaces. So size and location are very relevant. Size, of course, have been categorized as less than 100 and 100 to 200 and more than 200, classifying as a giant cyst. And the area of the cyst also. So a parafoveal cyst will not affect the vision much and is a good prognostic sign. And a last cyst at the fovea is a poor prognostic sign, especially if it involves both the inner and the outer retinal layers. And of course, many studies are there with correlating the size of the cyst with the extent and magnitude of macular ischemia. Another very common OCT biomarker we nowadays use and has been proven as a poor prognostic criteria is DRIL, that is a disorganization of retinal layers, and it is inability to distinguish between the inner layers, the ganglion cell layer, inner plexiform and inner nuclear, from the outer plexiform layers. This is measured in the central 1 mm zone, and more than 50% involvement of the central 1 mm zone is defined as drill. So it has to be proven as a reliable biomarker for the ad presentation for prognosis, long-term prognosis of visual acuity in DME. And of course, many studies have correlated its association with non-perfusion, size of the FZ, and increased severity of diabetic retinopathy as well as retinal vein occlusion. Hyperreflective dots, by definition, these are less than 30 microns, and they have absence of backshotting, so you have to differentiate between them and hard exudates. And more or less, the reflectivity is similar to the nerve fiber layer. And many studies have said that they are inflammatory markers, and also they respond very well with steroids as compared to anti-VEGF, but also they are associated with early recurrence. So if there are many HRFs, hyperreflective retinal foci, the patient should be frequently followed, because the recurrent edema chances are more in patients having HRF associated with macular edema. Hard exudates, these are similar to HRF, but larger in size. And of course, the area of involvement, the foveal involvement, implies poor prognosis. Integrity of ALM and EZ is also very important. Visual acuity has been shown to have a positive correlation with the survival of both these layers. Of course, refractory edema, TPH, and the taut posterior halide is a very important factor. Surgery is the only thing. It might resolve the foveal contour, but it might not correlate to the visual outcome. There are many other biomarkers because of the paucity of time. I'll skip to the next modality, that is FFA, and it has been considered to be the gold standard in studying the retinal vasculature. And now we are using mostly ultra-wide field imaging, and an extended field of view is crucial in these diseases for the diagnosis and the treatment and prognosticating the disease by imaging the peripheral retinal ischemia. And patients with extensive ischemia should be followed up more closely. So in this case, if the patient's presentation is florid, the patient has 6'9" or 6'6" vision because the macula looks okay, but there's a florid, proliferations. And I would counsel and even take a consent before lasering the patient because there's a high chance of vitreous hemorrhage post-laser. In this case, again, there are no massive proliferations, but the ischemia is involving the foveal center. So the prognosis is generally bad, even if the edema resolves. And in this case, the prognosis is very good because the FZ looks okay, and not a large amount of proliferation is there in the periphery. Skip this. This patient, again, with a 6'12", 6'9" vision, he was a one-eyed patient. The patient was doing well lasered, and I would not intervene, and it's a fair prognosis. Of course, I will closely follow up this patient and operate only if it involves the foveal center, as opposed to this patient, which was given an anti-VEGF for a macular edema. Supposedly, it was a tractional detachment, and now it has caused a combined detachment, and the prognosis is significantly less than the patient I previously mentioned. Coming to the last OCT angiograph, it provides detailed information of the retinochoroidal macrovasculature and can separately analyze each of the three capillary plexes. The caveats are long acquisition time, artifacts, and limited field of view. We all know it beautifully, tells you about the FAZ and the microorganisms and the involvement of the fovea. So to conclude, in the realm of retinal vasculopathies, whether it is diabetic retinopathy or RVO, every leak and every blockage tells you something about the systemic imbalance, and in the intricate network of retinal vasculature, abnormal systemic health is indicated. And apart from clinical examinations and advances, the advancement in multimodal imaging has come a long way in predicting and prognosticating the course of disease in the long-term management of these diseases and modifying the treatment in between. Thank you so much.
Thank you, Dr. Vishal. Beautiful wide field images. And for those who don't have that wide field imaging, I don't think we can prognosticate better. So, sir, your words.
As far as the diabetic macular edema is concerned, if there is edema, we treat. So we don't tell the patient like how much he's going to improve because we cannot prognosticate that. But then it helps us decide when to stop or continue the treatment. So that's what the prognostic factors help us in doing. So if there is drill and if there is chronic cystoid spaces, then we tell them we'll give an injection and see what happens. And if in case the patient's vision does not improve beyond a line or two, whether to continue the treatment or not is what the prognostic factors helps us. As far as the patient is concerned, we tell them yes, vision will improve. How much it will improve, we don't know. So most of the time, the subretinal fluid, they will improve quite significantly, but if the intraretinal fluid, long-standing cystoid spaces, they may not improve much, but they will improve. So it just depends on whether they respond to the injection or not. So I would still try to treat them and then see. But like we know mentally that like when do we stop the treatment or continue the treatment is what the prognostic factors will tell us. Another factor is the hard exudate clump at the macula. So these are things which you know that like the patient is not going to improve much, because even if the hard exudates go away, there can be an atrophy. That help us decide what kind of agent to be used. So most often we would prefer probably steroids, but though the anti-VEGFs have also been shown to make the hard exudates go away, but at a little later time duration as compared to the steroids. Presence of vitreomacular traction, Dr. Vishal did show a taut posterior hyaloid which is pulling it up. Those we would definitely operate, but there was a focal attachment which is just pulling up only the central fovea. I would probably not operate at the initial instance, inject and see. Sometimes despite the obvious looking VMT, the macular edema goes away. If it recurs much often, or sometimes the PVD may occur or because of the swelling going down as well. So in that situation, once again, that will help me prognosticate whether the patient will need a surgery or not. RVO, one thing I am still unable to prognosticate is the number of injections. I tell them that RVO patients may need lesser injections as compared to AMD, but sometimes like they keep needing injections over the next many, many years. So 5 years, 6 years also, some of them continue to need injections, so I am unable to prognosticate. So I usually tell them 5 to 8 injections the first year. Second year, third year, I tell them lesser number of injections, but like it's may not work all the time. One other thing which I look for in younger patients with vein occlusions, particularly central retinal vein occlusion, they may have a temporary or a partial central retinal artery occlusion. So we look for to see if in case there is whitening of the retina. So some of these patients have a perivasculitis, so that can cause this. So in that situation, they may present with a significantly poorer vision, in which case they actually have a very good prognosis also. And younger patient, I would usually treat them with oral steroids. So that seems to abort this optic nerve associated inflammation and the perivasculitis, and some of them may not progress as well. So I would usually treat them with steroids. And presence or absence of edema when they present initially is something which makes me decide how they will prognosticate, how they will progress. If there's no edema, but the patient has some vague symptoms and you know you have seen a central retinal vein occlusion, then I would probably call the patient about a week or two later. The moment some edema happens, then I will start injecting even if the visual acuity is 6.6, because then sometimes we are able to reverse the disease in these patients. CRVO, of course, the other prognostic factors which we always look at are the presence or occurrence of a relative afferent pupillary defect, ERG, as well as gonioscopy to see neovascularization. No, I don't go by the numbers at all. There are two situations what you're talking about. This is the initial attack of the disease and the patient has come with some cystoid spaces, but the visual acuity is still 6.6. If in that situation, if it's the initial attack of the disease and patient has come immediately after the occurrence of the disease, and even if there is mild cystoid space and visual acuity 6.6, I would treat the patient, particularly if young. As I mentioned, these are the patients I treat them with oral steroids as well, to see if you are able to stop the disease. Sometimes you are able to stop the disease. They do not progress. There's a reversal of the disease and the vein occlusion resolves and then it doesn't progress. But on the other hand, the patient has been having the symptoms for some time and then comes there with some cystoid spaces and probably some vision like 6.9, 6.12, but still it is not as thick as what it was. I would probably initially inject and see if the edema goes away associated with improvement in vision. If there is improvement in vision, then I'll probably follow them up closely to see if they need additional injections. But after the initial injection, they don't see any improvement visually, but the edema goes away, then I know that this patient has been having a chronic edema, and then I'll leave it. So, and I usually individualize the treatment for these situations.
even for a few weeks, they come back with a very bad ERD in some of these cases, and operating early when we see these cases, even if they have a mild fraction, like he had to wait. He said he will wait because he was a one-night patient. But I see that some patients they worsen very fast and they don't do well even after we do operate on this.
Yeah. Some of these patients, if you operate early enough, that the proliferation actually is easier to peel as compared to allowing them to become fibrous and then get attached to the drag the retina down. But on the other hand, if the patient has 6/6 vision and then if you operate, then there's a probability of losing vision because of retinal breaks and bleeding as well. So I usually don't operate if in case like there's no TRD or if there's no combined retinal detachment and the vision is still good, to see if they progress. So I would go ahead with the laser photocoagulation in the extreme periphery, leaving about 2 disc diameters of space from the neovascular proliferation beyond. So 2 disc diameters of space, you leave it and then go ahead with the laser photocoagulation. Telling them that like despite, not that because of the laser photocoagulation bleeding happens. What we tell them is despite the laser photocoagulation bleeding can happen is what you tell them. Despite the laser photocoagulation detachment can happen. But if you don't undergo laser photocoagulation, you're going to become blind. So that's what I tell them. And follow them up and see at the earliest sign of traction, and then like we find that like probably 1 or 2 lines decrease in vision, then we can jump in and do surgery. These are the like where you can give an anti-VEGF and within about 2 to 3 days you can do the surgery. Advantages like in these patients, actually the proliferation peels off easily. So the earlier you operate, younger proliferation actually peels off easily. But on the other hand, they can have increased risk of bleeding during the surgery. So immediate post-operatively, they may have recurrent vitreous hemorrhage, so it takes a little longer for them to recover vision. So we have to counsel them. So tomorrow when I remove the patch, you're not going to see much. So it's going to take, your vision is going to be much worse than what it is before the surgery. It may take about a month for you to get back the surgery. So I counsel them that way and then go ahead to the surgery. So yes, it's a sometimes very difficult situation, but very close follow-up and a graded laser photocoagulation is